Um, Thank you again for this kind invitation. This was a little in your usual style. I expected this to be a little more for cardio physicians, but I see a lot of cardiologists in the crowd. Pardon me if some of these concepts are basic. Nevertheless, let's go through some of the interactive ECGs. I'm going to talk about some of the arrhythmia related ECGs, and they will be talking about non-arrhythmic ECGs. Same thing, I made it an MCQ format. I don't know how this is going to be discussed. Do we have a way to discuss? Or so narrow QRS regular tachycardia rate of about 230. And again, to emphasize, when you look at it carefully, this patient has significant STT changes, QRS alternance, and cycle length alternance. Now, all these things put together makes it more likely to be accessory pathway mediated tachycardia. And accessory pathway mediated tachycardia, when the rates are more than 240, 250, have a significant risk, and this patient would probably benefit from a definitive therapy. And after conversion, this is what we have seen. Now, the second one is a patient, 66-year-old lady with SARS-CoV, admitted in the ICU with fever and cough after a 2-week course, and was treated for sinusitis and upper respiratory infection. It turns out to be COVID positive. So, azithromycin, hydroxychloroquine gets admitted with recurrent syncope. Now, again, to emphasize, you need to blow up the ECG, and when you look at it, the T wave offset, it almost goes on till the next cardiac cycle, and the corrected QT is 620. So rightfully, this patient had a torsades, and the guideline recommendation is if it's more than 500, please do not give azithromycin, choose doxy. No hydroxychloroquine in this patient if the QTC is prolonged. 450 to 500, if you give, you need a closer monitoring of ECG repeatedly. Whatever it is, these patients would first have their electrolytes optimized before you start these drugs. Now, I'm going to present 2 or 3 patients with right bundle branch block ECGs. This is a patient who's come with an exertional dyspnea and 1 episode of presync. What is the diagnosis? It's incomplete right bundle branch block, Brugada syndrome, ARVC, or sarcoidosis. We have some volunteers.
Dr. Narasimhan, you please discuss.
Okay. Now, the most important thing we should understand is when you take a right bundle branch block, the initial activation is unaltered, left to right of the septum, and the RV activation is unopposed, and that is inscribed by the R prime. When you see an R prime, yes, and the R prime should be taller than R in a typical right bundle branch block. If the R prime voltage is very low, this is not a regular run-of-the-mill right bundle branch block. This patient has an RV disease. And this most likely this patient, I mean, he was confirmed to have an ARVC by MRI, and we were able to induce a sustained monomorphic VT on this patient. So right bundle branch block is a common thing that as physicians we see, but when you see an R prime that is smaller compared to the R, you should suspect that there is a myopathic process in this individual. So as again I said, the R prime is the usual dominant vector in a person with a typical right bundle branch block. Similar right bundle branch block patient, very similar history. Is it incomplete right bundle, first degree AV block, old inferior MI because he has got a Q in inferior lead, but no Q in lead 2, Brugada syndrome, ARVC, or sarcoidosis. Now, my colleague Dr. Deb has actually written a very nice, there are simple electrocardiographic clues to suspect sarcoid. When you have a person with PVC and having a conduction disease like a first degree AV block, Q waves, and what you see here in, let me just, so you see a Q wave predominantly in the infero-posterior leads. There is evidence of fractionation you can see in lead V2. There is evidence of a widened QRS and a delayed activation of the RV, which is not conforming to anything. So these things should make you suspect that this patient has a granulomatous myocarditis. This is what Dave looked at. Patients who were passed off from centers as routine routine patients with RVOT-VT or benign PVCs, if they have a presence of a fascicular block or a bundle branch block, there's a very high probability that it is underlying granulomatous disease. If that is not present, he looked at whether there is a QRS fragmentation. If it is present, it's more likely to be sarcoid. Third is, when there is inflammation of the myocardium, you find there is edema. And all of you know, when there is edema of the myocardium, the QRS voltages becomes low. And that, again, inferior lead showing a low QRS voltage in the presence of a right bundle branch block should make you suspect that it's sarcoid. This is a classic example of what you can see as a fractionation. Initial deflection is very well seen, and then a mid QRS notch, and this is typical fractionated QRS, which if you see this in a person with even who comes for a PVC evaluation, you, instead of saying this is benign PVC, put him on beta blocker, you should evaluate these patients further. This is a 17-year-old boy who was came to us from another patient. He's being written up by one of my colleagues now. Had recurrent seizures, was admitted there, initially was given IV midazolam, was loaded fully with Eptoin, but the seizures kept on increasing to the point they needed to paralyze and ventilate him. And what is this? Right bundle, Brugada, PTE, normal variant. Now, what I would like to emphasize is this is called Chevalier's angle. Chevalier's angle is this group. When we see a patient as a clinician, we need to make a bedside decision. Several patients with incomplete right bundle branch block come to us with syncope, pre-syncope. You can't be evaluating every one of them for a possible Brugada. So when you see the R prime angle, which is very sharp compared to Brugada, where the base is very wide. So when you see this angle to be very wide, that is more likely to be Brugada syndrome. This was first described by a guy called Chevalier from France, and later it was modified by several other investigators. So one of the single clue is the STT, it merges such a way that the base becomes very broad in Brugada compared to a run-of-the-mill right bundle branch block. This is often seen in thin individuals who are with a pectus excavatum. A lot of other things can cause. You need not be evaluating all of them for a possible Brugada. The other thing that I would like to emphasize here, this is a classic thing, one of our security guard with a classic Brugada, and he's symptomatic, but can't afford an ICD. This is a common problem for all of us. All the guidelines say give an ICD. Look at this. This angle becomes broad. That is very typical of Brugada. Let me go back to this patient. When you give a sodium channel blocker like Eptoin, fosphenytoin, or any of the anticonvulsant agents, all of them will worsen the Brugada syndrome. So because you're blocking the sodium channel, you're actually unmasking the Brugada. This patient came to us in a VF storm, and this is what after VF he kept happening. paradoxically, this is the only condition where all the antiarrhythmic drugs like sotalol, everything will worsen the situation except isoproterenol. It is counterintuitive, but isoproterenol is a drug which will be useful and it will help you to tide over this crisis. And that's what we did for this patient. We were able to tide over the crisis with isoproterenol. I'm going to dwell, we are always talking about guidelines. Please understand, 95% of patients who come with Brugada syndrome, they cannot afford an ICD. And some of them don't have syncope. What do you recommend? Now, common sense approach is anything that increases severe vagotonia at night will increase the Brugada pattern. So ask them to avoid alcohol, ask them to avoid heavy meal, rice eating at nights. These are all things which can open up the ITO channel and make the VF syndromes much more frequent. Alcohol, heavy carbohydrate meal, fever, just like pediatricians advise for a febrile seizure, the moment there is a fever, ask them to take Q6H paracetamol. Do not prescribe tricyclic antidepressants and antihistamines for this patient. So these things are common sense approach for 95% of the, because Brugada patient has been having for 40 years. Suddenly one night he decides to have this VF and he succumbs. So these are things which we follow in practice and we found to be very useful. Do not use beta blocker in this patient because they tend to worsen the situation. This is a 54-year-old person with dilated cardiomyopathy. Mild palpitation was the presenting symptom. No history of diabetes, hypertension. Was on adequate dose of beta blocker and the ACE inhibitors. Normal effort tolerance. Presence with normal vitals. EF is 30%. And because of the palpitation, he was asked to be evaluated with a prolonged monitor. And he came with this monitor. Actually, he was referred for an ICD. Would you increase the beta blocker, add amiodarone, give ICD? He's little hesitant because of the cost, or go with MRI.
It's an artifact.
So... Exactly. So what you see is you can march these high frequency components. If you take a caliper and march, every RR cycle, there is a RR that is hidden there. That is one of the simple things that when you put a Holter for recording, the commonest reason for this is spectralis activity. When a person brushes the teeth or anything, it will produce this kind of frequency that is recorded. So ensure that the leads are placed on a bony point, on the rib, rather than on the muscle. That tends to minimize this, and it's fairly adherent. So this person, if his MRI, there is enough data following Danish trial that if MRI is normal, doesn't show a scar in DCM, there is no urgency to put an ICD. We can manage them with medical therapy, except for, there are some exceptions, but we'll come back to it. So this turned out to be an artifact. This is another example, again, to tell you how to recognize an artifact. Take a caliper, measure the RR interval, and when you actually put the next RR, there is high frequency deflection, another high frequency, another high frequency, another high frequency. Hidden here, here, here. So, and the second thing is following the so-called arrhythmia, when it terminates, if there is no pause, immediately the QRS comes. That should again make you suspect it's an artifact. The other option is you can go back and march it out this way, and sure enough, there is a high frequency deflection saying it's an artifact. This is a 27-year-old school teacher with recent onset of dyspnea, EF of 40%, mid-range ejection fraction. He came with this ECG. Again, to the point of parrot-like repeating, we would like to see this. This patient was actually referred for an ablation for an accessory pathway, pre-excited AFib. This is not pre-excited atrial fibrillation. This is pleomorphic VT. When you have two distinct morphology, this is left bundle morphology. This is right bundle morphology. Again, left bundle, right bundle. So it's again not bidirectional VT. There are two distinct morphologies which keep simultaneously running. This is an indication of an active inflammation of the myocardium, and this patient turned out to have a myocarditis. Any kind of myocarditis, including giant cell, can cause this kind of a problem. So pleomorphic VT of recent onset, please suspect underlying myocarditis, because that's what is our finding. This can also be seen in a terminal heart disease when there's extensive fibrosis. That you cannot do much for that patient. But if you have a preserved EF and the patient presents with this is a fatal condition, but if recognized and treated, you can really prevent a transplant in some of these patients. This is a 63-year-old retired, actually a physician from a government hospital, well-controlled diabetes, hypertension, undergoes a CAG for a chest discomfort, mid-LAD lesion, was stented with a drug-eluting stent, presence with intermittent palpitations 2 months later, and this is the electrocardiogram. Would we continue beta blocker and dual antiplatelets, or stop the aspirin and add apixaban, continue the ticagrelor, or add apixaban in addition to DAPT? What will we do? Any takers? Now, because the trials don't really address these things, if you look at every atrial flutter fibrillation trial, if you get rid of the flutter and fibrillation, your risk of arrhythmia, stroke comes down significantly. Similarly, if you have a person with triple vessel disease who has a AFib, instead of putting a stent and getting into this, if it's a surgical case, better get him surgically revascularized. This actually is not a AFib. This patient has an AV dissociation. You can see a clear P wave in lead 2 here. You cannot have an organized atrial activity which is going on in the presence of atrial fibrillation. So there is a ventricular rhythm which is going simultaneously with the atrial activity. There is a VA dissociation. This is a left bundle right axis deviation with a Q in lead 2 and AVL, suggesting it's coming from the basal septal involvement with irregular VT and VA dissociation. Again, this is an irregular VT. We gave just a Xylocard for this patient and completely everything settled down. And you need not give an apixaban and unnecessarily expose this patient for a lifelong commitment to anticoagulation, because there is a greater and greater emphasis on what is the correct threshold, what is the correct dosage of drugs and other things. But I think what is more important is to make a decision whether it is required or not. For example, the most difficult thing for a physician who saw that a 17-year-old boy was to differentiate whether it was a seizure or whether it was a cardiac syncope which was presenting as seizure. Luckily, this patient was picked up, and otherwise we would have been on lifelong drugs which are not going to be effective. This is a 78-year-old person with syncope while walking with a normal effort tolerance. What do we think? Slow VT, he needs an angio or a PPI. This is a classic manifestation of a right bundle branch block. When the PR shortens, it goes through the left bundle. So alternatively, when there is a right bundle branch block, the impulse is traversing through the left bundle here. The left bundle gets blocked, it's traversing through the right bundle. So at one point, even when there is a long PR, both the bundle branches are not able to conduct together. So this is a very typical manifestation of a bilateral bundle branch block, and this patient needs a pacemaker without any further evaluation. This is a patient, actually this outcome was excellent in this patient, 72-year-old person diagnosed to have DCM, essentially presented with a tachycardia, and blood pressure was well maintained, and he needed oxygen at the time of presentation, and he was dyspneic. Despite Lasix, enalapril, amiodarone, carvedilol, he was quite symptomatic. EF of 28%, moderate MR, and this is the electrocardiogram. So, was it atrial fibrillation with rapid ventricular response, atrial flutter, or AV nut? Instead of being dogmatic about a diagnosis, I'm just going to say all of us at some stage, we are not sure what the diagnosis is, how to proceed next. The next thing is do a vagal maneuver, just a simple carotid massage or an adenosine. You have brought out all the flutter waves. Now, why is this important? Because flutter is a very simple arrhythmia for you to treat, and it can be permanently gotten rid of. So appropriate treatment for this patient, because he was very sick, would we give delta SM for rate control or increased amiodarone or DCCB? Actually, the correct option is none of the above. Because when you have an atrial flutter in a person with uncertain duration and LV dysfunction, you cannot cardiovert unless you have done a TE or you have given prior anticoagulation to this patient. So this patient was started on anticoagulation, was cardioverted later, improved, and the MR also became very mild, and EF improved, but has a recurrence. Now, at this stage, you know for sure, despite all the best medical therapy, he is having a recurrence, and you need not commit him for lifelong anticoagulation at 60 years of age. Just get rid of the flutter permanently with a catheter ablation, and then nothing further is, this person is not going to need anything further. So atrial flutter patients also will require anticoagulation, especially if you're planning cardioversion. Rheumatic atrial flutter fibrillation, especially, they will need a anticoagulation. When in doubt, record the ECG during a vagal stimulation. And differentiating this flutter from fibrillation is important, because flutter, the result of ablation is much better, and the recurrence rate is minimal when you get rid of the flutter in these patients. This is again a classic pre-excited atrial fibrillation. Just to say that the current guidelines do not recommend amiodarone for these patients, and this patient was mistaken as atrial fibrillation. And one thing which shouldn't be given is IV adenosine or digoxin, which worsens the conduction through the accessory pathway. This is a 63-year-old lady, came with irregular palpitation, and was referred for atrial fibrillation, was on anticoagulation with metoprolol and anticoagulation. Now, whenever you see an irregular rhythm, you don't have a simultaneous prolongation of the QRS, and the QRS becomes narrow, QRS becomes wide, QT becomes wide, this becomes so. When you see this kind of a pattern, this is not a regular atrial fibrillation. This is a lag in your ECG recording machine, which causes this kind of a problem. You see here the QT becomes abruptly shortened, whereas when this is there, the QT becomes longer. That should give us a clue that this is related to the ECG. This is more common in the analog recording of Holter machines. Some of these things can be misinterpreted as atrial fibrillation. All that is labeled as AFib may not be AFib. So look at the raw data, look at the patient before committing. That is what is going to make us better clinicians. Patients with palpitation and presyncope, again, came with Holter for this broad QRS rhythm. Whenever you see a broad QRS tachycardia initiated by an atrial ectopy, P wave, suddenly an atrial ectopy happens here. One normal, again, an atrial ectopy starts this broad QRS rhythm. Most likely, it is a supraventricular tachycardia with aberrancy. Similarly, the final thing which terminates this, you see this peaked P waves that is sitting on the T wave, something like a spike. This spike, the third spike stops the tachycardia. So when the impulse comes down through the AV node, there is a AV nodal block which terminates the tachycardia, which tells you that this is going to be a simple AV node dependent tachycardia, and that has conducted with aberrancy. So looking at the onset of the tachycardia, whether it starts with a QRS or with a P wave, whether there is a PR truncation at onset, the way it terminates will help you to confirm the diagnosis. This is actually supraventricular tachycardia with aberrancy, and most likely this is going to be AV node dependent tachycardia. So look at the onset and termination of a tachycardia. A tachycardia that ends with a P wave is unlikely to be an atrial tachycardia. It's more likely to be AV node dependent tachycardia. This is a patient who has undergone a CRTD and then came for follow-up, went back, and then came back saying that he has a worsening heart failure. What do we think is the cause of the worsening heart failure? Again, to show that this patient has a paced rhythm, right bundle branch block morphology, Q in lead 1, but after a certain beats, this becomes broad QRS, and there is a fusion. This is a fusion between the broad QRS and the paced beats. So whenever a patient with CRT develops a slow VT, this is very common in India because we keep loading these patients with amio, and the VT doesn't disappear, it just slows down. So when the VT slows down below the rate cutoff of a CRTD, the device will not fire or will not pace to terminate. It will only pace at a LRL or at the upper tracking rate. And whenever this VT is there, it will just present as unexplained heart failure. So both atrial and ventricular arrhythmias, even when they are frequent and non-sustained, is a common cause of worsening heart failure in CRT patients. You should suspect this, especially when a person has initially improved and then he comes back with this kind of a thing. Go back through the arrhythmia logs, the frequent PVCs, percentage of PVC and percentage of biweek pacing is less than, say, 85%. You should think that the PVC is preventing the CRT delivery, and you should get rid of this as a permanent solution. This 45-year-old person with dyspnea, 1 episode of syncope, family history of sudden cardiac death, father died suddenly, and this is the ECG. Long QT, HCM, ischemic VT-VF. This is a very typical example of STT alternance. The ST way, this is critical ischemia or global ischemia can cause this. When the ST alternatively becomes too deep and less deep, too deep, less deep, this is a typical sign of a severe ischemia. This can also be seen in patients with very severe hypertrophied ventricle, suicidal ventricle. When they have in HCM, during even mild exertion, they can develop this. So coronary angiogram, if it is normal, an MRI in this patient is necessary, because anything that decreases the microvascular perfusion can cause this. And that happens at the level of the arterioles in HCM that can typically present this way. This is a 78-year-old person following a pacemaker, has gone back and presents with presyncope and palpitation, dizziness and palpitations. What is the diagnosis? What is the problem? Atrial undersensing? Is it atrial tachycardia? Is it a runaway pacemaker, or is it loss of atrial pacing which is causing the pain? Let me just walk through. The first is atrial sensed V pace. Here again, A sense V pace, A sense V pace. Then here is A pace V pace. Here there is a spike, A pace. It hasn't captured the atrium, but it has captured the ventricle. Ventricular beat has been captured. Because the AV node is not depolarized here, it was available for the ventricular pace beat to come back and cause a retrograde A. and set up a pacemaker-mediated tachycardia. So the cause of the pacemaker-mediated tachycardia here actually is loss of atrial capture. So that is one of the common reasons, is either undersensing or loss of capture of the atrial lead is one of the common reasons for pacemaker-mediated tachycardia. So please ensure that your atrial sensing and pacing is all right in all your dual chamber pacemakers. I think I'll probably stop with this last patient with severe heart failure despite optimal medical therapy. Next therapy would be EF of 25%, right bundle morphology. Do you think it will go for CRTD, CRT pacing, ICD, or transplant? This is again to emphasize, you see a small evidence of a septal scar in the form of a Q wave in lead V2. You're not supposed to see any Q wave in these leads. It indicates it's an ischemic cardiomyopathy. Second thing is the right bundle is not a pure right bundle because you don't have an S wave in lead 1 and AVL, which tells you that there is a disease of the contralateral bundle branch also. So this patient has got a typical masquerading bundle branch block. All of us know that a efficacy of CRT is not very good in the presence of a pure right bundle, but that doesn't apply for masquerading bundle branch block. Patients with masquerading bundle branch block will still derive benefit from CRT, and this patient actually underwent a CRTD with a good outcome overall. So I think I'll stop with this. If there are any questions, we'll be happy to take thereafter.
I don't find any in the chat box. Munna, you can ask.
Yeah,
Dr.
Hello.
Munna and Suchit,
Hello,
yeah,
Dr. Narasimhan. Yeah,
please.
Dr. Narasimhan, am I audible to you?
Yes, yes, very well. Hi,
Okay.
Munna, go ahead.
So one ECG that you had discussed regarding the diagnosis of ARVD, your sarcoidosis
Yes,
with the right bundle branch block morphology, but with fractionated your QRS in the your V1, V2.
yes.
There actually means how common is sarcoidosis overall vis-a-vis your RV infarct and inferior wall MI, because that patient also had Q waves in the inferior leads, only that the lead 2 didn't have a Q wave but was had a decreased R wave amplitude. That is also a Q wave equivalent. A fractionated QRS or a decreased R wave amplitude is also a Q wave equivalent, because we need to rule out the coronary anatomy disease prior to clinching our diagnosis in favor of sarcoidosis. Do you agree, sir?
Yes. Now, the reason I put it is because there are other things I didn't want to discuss here. This patient has got evidence of poor R wave progression V1 to V3. And there is evidence of let me just bring up this laser pointer. Now, whenever you see, we'll go back to our old ECG textbooks. When you see QS complex in lead 3 and AVF, what decides the specificity of inferior wall infarction is to look at lead 2. Shamroths and others, they've looked at, because all of us know that in obese people also you can get some physiological Q wave. But when there's no Q wave in lead 2, it's highly unlikely to be inferior wall infarction, but there are exceptions. Second thing is the company it keeps. The company of a first degree AV block conduction disease, the septal involvement in terms of loss of R wave from V2 to V3, the amplitude is coming down. There is a delay in the initial portion of the QRS and a terminal delay. So this is biventricular involvement. There are a lot of things in this ECG which suggest that it is more than, yes, I agree. In this age group, you should probably rule out a CAG The reason I put this up is people tend to believe that this disease we are overdiagnosing. It is not. We feel that this is an underdiagnosed entity, and usually the ECG gives a lot of clinical clues to this diagnosis. And similarly, this is a terminal delay, which is suggestive of a myocardial cell-to-cell conduction that is abnormal. And these are the reasons why we suspect it. But your point is well taken.
And sir, one thing in the Brugada diagnosis, the
Yes.
guidelines have not yet put the Chevalier's angle.
No, the thing is, when practically a physician is seeing 100 patients, if he sees ECG like this in a person who has got a presyncope versus a person like this, typical right bundle. So how does he think of Brugada is just look at this. That is what we are emphasizing. Very often young adults, athletic adults will have an incomplete right bundle branch block. These patients we start investigating, then we'll be sending a lot of patients for genetic testing and so on and so forth. It's only an added clue for you.
Okay, sir. Thank you.
So that ARBC ECG, I thought one important point is there in that first ECG of right bundle.
Yes.
Yeah, that here also the QRS duration is more in this V1, V2, and V3, rather than it is not there in V6 or V5. This change is also one of the indicators of ARBC.
Exactly. Very, very true. I hope people, Suchit rightly pointed out that the QRS duration in V1 is much prolonged compared to V6. That is an indirect evidence of ARBC. That's one of the criteria. You're right.
Any comments or questions? I don't find any in the chat box.
Dr. Narasimhan,
Yes,
Shubhra Banerjee, I had a question. Like you did mention about stopping oral anticoagulation after ablation of atrial flutter in one of the cases. But do you do that for all cases, or does it also depend on the Schatzbach score? If it's because you never know when they can recur.
That's a very, very pertinent question. So if a person's CHAD score is high and if the patient is not on dual antiplatelets, I continue for a longer period and adequate monitoring. On the other hand, if you have a person who is already on dual antiplatelet and he doesn't have any evidence of atrial fibrillation whatsoever, and especially the advantage is when you do this kind of that's what you asked is a very pertinent question. You should ask the EP to test for AFib on the table also. Despite aggressive testing for atrial fibrillation, you don't induce AFib at all. It gives me a little more of satisfaction by withholding anticoagulants in that patient. But if you don't have this at the bedside, CHAD score is high and a patient has flutter, and even if flutter is ablated, it's prudent to continue anticoagulation as long as the risk benefit is in favor of the benefit.
Yeah, thanks.
Sir, one question to you, sir. What will you do in a patient who has also one ECG showing atrial fibrillation in that flutter? How will it change your management?
Yes, the thing is very
mostly
often,
flutter, one showing.
What happens is flutter can initiate atrial fibrillation, and PACs can conversely atrial fibrillation can initiate a flutter. So I don't go in for a PV isolation straight away. I just get rid of the flutter, wait and watch. But if the patient's all the Holter recording 9 out of 10 is only got an atrial fibrillation, then it doesn't make sense to go and ablate the flutter alone. So you need to think what has to be done for AFib.
So flutter ablation plus flecainide may be good.
No, if patient anyway, I'm going to give flecainide. I don't do a flutter ablation. I first try drug therapy.
Is there any other question? Otherwise, I thank Dr. Narasimhan.
Thank you very, very much.
Thank you very much.
Thank you, sir.
And nice meeting you after some days.
Sure. Thank you. I also enjoyed the meeting. Thank you.
Thank you very much. So next session is this other part of the ECG, that is a non-arrhythmic changes by Dr. Devabrata Bera. To chair the session, Dr. Dipankar Mukherjee is sick, he couldn't make it. So may I request Dr. Bappaditya Kumar and Dr. Shuchit Mojumdar to chair the session. Dr. Narasimhan, how long you will be here?
Probably another 10 minutes. I have a board meeting at 4.
Okay.